Welcome to Lesson 3 of your Intrapartum unit. In this lesson, we will discuss the concepts of fetal assessment during labor. The objectives of this lesson are to identify the signs of normal and abnormal fetal heart rate patterns, to compare fetal heart rate monitoring performed by intermittent auscultation with external and internal electronic methods, explain the baseline fetal heart rate and evaluate periodic changes, describe nursing measures that can be used to maintain fetal heart rate patterns within normal limits, differentiate among nursing interventions used for managing specific fetal heart rate patterns including tachycardia and bradycardia, absent or minimal variability, and late and variable decelerations. Also, to review the documentation of monitoring process during labor. Electronic fetal monitoring is a useful tool for visualizing fetal heart rate patterns on a monitor screen or printed tracing. It was first used in the 1970s. The anticipated effect was a decrease in cerebral palsy. However, the rate has not declined. The primary mode of intrapartum assessment in the United States is fetal monitoring. The basis of fetal monitoring. Labor is a period of physiologic stress for the fetus. Frequent monitoring of fetal status is part of nursing care during labor. Fetal oxygen supply must be maintained during labor to prevent fetal compromise. Fetal oxygen supply can be decreased due to reduction of blood flow through maternal vessels as a result of hypertension and hypotension, reduction of oxygen content in the maternal blood as a result of hemorrhage or severe anemia, alterations in fetal circulation with compression of umbilical cord, and reduction in blood flow to intervillous space of the placenta. The maternal basis for fetal monitoring includes normal uterine activity during labor, monitoring the frequency of contractions, the duration of contractions, the strength of contractions, the resting tone, and the relaxation time. Let's discuss contractions. The frequency of contractions is defined as the length of time from the beginning of one contraction until the beginning of the next contraction. The beginning of one contraction till the beginning of the next contraction. Generally, there are 2 to 5 contractions will be seen every 10 minutes during labor, with lower frequencies seen in the first stage of labor and higher frequencies, up to 5 per 10 minutes, seen in the second stage of labor. The duration of the contraction is from the beginning of this contraction until the end of that contraction. Beginning, end, beginning, end. Duration remains fairly stable and ranges from 45 to 80 seconds, not generally exceeding 90 seconds. Strength of the contractions generally range from peaking at 40 to 70 millimeters of mercury in the first stage of labor to over 80 millimeters of mercury in the second stage of labor. In order to accurately measure the intensity of uterine contraction, an internal uterine pressure catheter should be in place. The water must be broken for insertion. If the water is not broken, the intensity of uterine contractions must be palpated. During a uterine contraction, the nurse would palpate the fundus of the uterus. If the nurse can indent the uterus and it feels like the tip of the nose, the contraction would be documented as mild. If the intensity is like the chin, the contraction would be moderate. If the intensity is like the forehead, it would be documented as strong. The resting tone is the baseline between each contraction. This is the resting tone. The average resting tone during labor with an internal monitor is 10 millimeters of mercury. If palpating, it should be easily indented or soft when the uterus is resting. Relaxation time is commonly 60 seconds or more in the first stage of labor and 45 seconds or more in the second stage. Relaxation time is the time that the uterus is resting. Montevideo units are a unit of measure used with an internal fetal monitor. They usually range from 100 to 250 in the first stage, rise to 300 to 400 in the second stage. Contraction intensities of 40 millimeters of mercury or more and Montevideo units of 80 to 120 are generally sufficient to initiate spontaneous labor. MVUs are used only with internal monitoring. Fetal well-being during labor is measured by a response of the fetal heart rate to the uterine contractions. Reassuring fetal heart rate patterns are a baseline fetal heart rate in the normal range of 110 to 160 beats per minute with no periodic changes and a moderate baseline variability. In the preterm infant, baseline fetal heart rate may be higher. This shows a baseline fetal heart rate. The baseline is measured between changes, so during this contraction, this would not be considered baseline. Between each one of these contractions, or between any accelerations, there are no accelerations on this, and any decelerations, there are no decelerations. So the fetal baseline would be what you would see between these contractions. The baseline of the fetal heart rate is the average fetal heart rate over 10 minutes, rounded to the nearest 5 beats per minute. In this case, it would be around 145 beats per minute. The goals of intrapartum fetal heart rate monitoring are to identify and differentiate the normal patterns from the abnormal patterns which can indicate fetal compromise. Non-reassuring fetal heart rate patterns are associated with fetal hypoxemia. If uncorrected, these patterns can progress to fetal hypoxia. In this slide, you see the nurse demonstrating a method of non-electronic fetal monitoring. She is using the Pinard stethoscope method. This slide shows other methods of intermittent fetal monitoring. A is the ultrasound fetoscope. B is the ultrasound stethoscope. This one's also called Doppler. A is also called Doppler. B is also called the ultrasound stethoscope. And C is the DeLee-Hillis stethoscope. Intermittent auscultation is an easy-to-use, inexpensive, and less invasive method of monitoring the fetus during labor. It is more comfortable for the woman and gives her more freedom of movement. However, because it is intermittent, significant fetal events can occur between times when the heart rate is monitored. Intermittent auscultation does not provide a permanent record of the fetal heart rate. It has been recommended by the American College of Nurse Midwives from the U.S., Great Britain, and Canada that low-risk women be monitored every 15 minutes in the active phase of the first stage of labor and every 5 minutes during the second stage of labor. However, the Association of Women's Health Obstetric and Neonatal Nurses, or A1, recommended every hour in the latent phase of the first stage of labor and every 30 minutes in the active phase of the first stage of labor and every 15 minutes in the second stage of labor. In order to accurately check the fetal heart rate, the nurse should palpate for contractions, begin listening at the beginning of the contraction, and continue to listen until after the contraction has completed. When the nurse spends this amount of time assessing the fetus, the nurse will need to remain at the bedside. This requires a 1-to-1 staffing ratio. At the point that 1-to-1 staffing cannot be met, the patient will need continuous external fetal monitoring begun. Electronic fetal monitoring. The purpose of electronic fetal monitoring is ongoing continuous assessment of the fetal oxygenation. And using EFM, the nurse will be able to analyze the fetal heart rate tracings to assess for events that indicate fetal hypoxic events and metabolic acidosis in labor. There are 2 ways in which a woman can be monitored using electronic fetal monitoring. The first is external monitoring. External monitoring is accomplished using a fetal heart rate ultrasound transducer and a uterine contraction Toco transducer. Internal fetal monitoring is invasive and uses a spiral electrode that is attached to the presenting part of the fetus and a intrauterine pressure catheter to assess uterine activity and uterine resting tone. A combination of external and internal may be used, with the most common combination being a spiral electrode in combination with an external uterine contraction monitoring transducer. In some states with special training, nurses may place both spiral electrode and IUPC. In the state of Missouri, the Nurse Practice Act does not specify whether an RN may perform these procedures. The Missouri State Board of Nursing allows facility to decide what the nurse can do. Some facilities are more conservative and require that a physician place both the spiral electrode and the IUPC, while others allow nurses to place one but not the other. In your books is a table that compares the internal and external methods of fetal monitoring. Please review this table. The ultrasound transducer works by reflecting high-frequency sound waves off of a moving interface, in this case the fetal heart and valves. There is some difficulty in maintaining a continuous tracing due to artifact produced by fetal and maternal movement. Other factors may make it difficult to maintain a continuous tracing. Maternal obesity, the occiput posterior position of the fetus, and the anterior attachment of the placenta can cause weak or absent signals. The paper speed of the external fetal monitor is 3 centimeters per minute. Once the area of maximum intensity of the fetal heart rate is located, a conductive gel is applied to the surface of the ultrasound transducer, which is placed over this area and held in place by elastic belt. In this place you see the ultrasound transducer placed on the woman's lower abdomen. You see the position of the fetal back. It's usually at the fetal back where you're going to find the greatest heart rate, and it's there where you can see it. In this one you see the lady with the belt placed around the cardio monitor. The Toco transducer or Toco dynamometer measures uterine activity transabdominally. The Toco is placed over the fundus above the umbilicus and held with an elastic belt. Uterine contractions or fetal movement are detected by a pressure-sensitive surface on the side next to the abdomen. The Toco can measure the frequency and approximate duration of the uterine contractions, but it cannot measure the intensity. The external Toco is designed to measure uterine activity at term and may not be sensitive enough to measure contractions in a preterm pregnancy. Here you see the placement of the Toco transducer on the fundus of the uterus. Here you see the same thing. There is one caveat. You will need to move this from time to time. If a woman has a long labor with an external transducer, it can cause some breakdown if you don't move it around. This monitor shows a wireless and beltless device that can be used to obtain fetal heart rate via abdominal electrocardiogram. The monitor is called the Monica AN24. It is capable of monitoring both the fetal and maternal heart rates and an electromyogram from the uterine muscle. You see how the electrodes are placed around the abdomen. It allows the woman to have much better movement. You see this woman is sitting on a birthing ball. She's still being monitored. This woman is ambulating. In this slide you see the internal monitoring of both uterine activity and a spiral electrode. The IUPC, or the intrauterine pressure catheter, is floating in the amniotic fluid in front of the baby. The spiral electrode is attached to the fetal scalp. The baseline fetal heart rate is the average rate during a 10-minute segment that excludes periodic or episodic changes and periods of marked variability and segments of the baseline that differ by more than 25 beats per minute. There must be 2 minutes of interpretable baseline data in a 10-minute segment of tracing to determine baseline. After 10 minutes of tracing is observed, the approximate mean rate is rounded to the closest 5 beats per minute. The variability of the fetal heart rate may be described as irregular waves or fluctuation in the baseline fetal heart rate of 2 cycles per minute or greater. There are 4 possible categories of variability: absent and minimal. Absent demonstrates an amplitude range that is undetectable. Minimal has an amplitude range of less than or equal to 5 beats per minute. Moderate or normal variability has an amplitude range of 6 to 25 beats per minute. Marked variability has an amplitude range of greater than or equal to 25 beats per minute. Absent or minimal variability can be classified as either abnormal or indeterminate and as a result of fetal hypoxemia or metabolic acidemia. Absent or minimal variability is also caused by the CNS depressant medication, such as analgesics, narcotics, barbiturates, and phenobarbital, tranquilizers, phenothiazines, and general anesthetics. Minimal variability can occur with tachycardia or prematurity. It can also occur when the fetus is temporarily in a sleep state. Sleep states generally do not last longer than 30 minutes. In the top slide you see absent or undetectable variability. If you'll look, there are no variations in the fetal heart rate. And you'll also see that's a little bit tachycardic in the baseline. In B, in the bottom one, you see minimal variability. You do see some fluctuation in the baseline. In this case, we have a fetal heart rate baseline running about 130. In this slide, you see normal variability. If this were an adult strip, you would be very concerned as this looks remarkably like ventricular fibrillation. This is a joke, guys. Moderate variability is considered normal and is predictive of a fetus with normal acid-base balance. If moderate variability is present, most of the time it indicates that the fetus is not affected by fetal sleep cycles, tachycardia, prematurity, congenital anomalies, pre-existing neurologic injury, or CNS depressant medications. In this slide, you see marked variability. The significance of marked variability is not entirely clear. On this slide, you see what is called a sinusoidal pattern. A sinusoidal pattern demonstrates regular, smooth, undulating wave-like pattern. This is an uncommon pattern that is classically associated with severe fetal anemia. Variations of the sinusoidal pattern have been associated with chorioamnionitis, fetal sepsis, and administration of narcotic analgesics. Variations in the baseline fetal heart rate also include tachycardia, which is a baseline more than 160 beats per minute for a duration of 10 minutes or longer, and bradycardia, which is a baseline less than 110 beats per minute for a duration of 10 minutes or longer. This slide shows fetal tachycardia. The fetal heart rate is greater than 160 beats per minute. Where this pointer is going is 160, and you can see the fetal heart rate is well above that 160. This case is running about 170. Fetal heart rate tachycardia is generally considered an early sign of hypoxemia, especially if it is associated with late decelerations and absent or minimal variability. If you will notice, the fetal heart rate in this also has minimal variability. Fetal tachycardia can be caused by maternal or fetal infections such as prolonged rupture of membranes with amnionitis, from maternal hyperthyroidism or fetal anemia, or in response to medications such as atropine, hydroxyzine, terbutaline, or illicit drugs such as cocaine or methamphetamines. Bradycardia, or a fetal heart rate less than 110 beats per minute for 10 minutes or longer. True bradycardia rarely occurs and is not specifically related to fetal oxygenation. The difficulty lies in distinguishing true bradycardia from prolonged decelerations. These must be distinguished because the treatment for each is very different. True bradycardia is often caused by some type of fetal cardiac problem, such as structural defects involving the pacemakers or conduction system, or fetal heart failure. Other causes include viral infections such as cytomegalovirus, maternal hypoglycemia, and maternal hypothermia. The significance depends on whether there are other periodic changes such as accelerations or decelerations. In your book, there is a table that compares tachycardia and bradycardia. You should review this table. In this heart rate pattern, you see the heart rate is running at about 100 beats per minute, which is below the normal 110 beats per minute. The changes in fetal heart rate include periodic changes that occur in the fetal heart rate in association with uterine contractions. Episodic changes or non-periodic changes are not associated with uterine contractions. Accelerations in the fetal heart rate are defined as visually apparent abrupt increases in the fetal heart rate that from onset to peak are less than 30 seconds. Decelerations are caused by a dominance of parasympathetic response and may be benign or abnormal. Decelerations are described by their visual relations to the onset and end of a contraction and by their shape. You have either early decelerations, which is response to fetal head compression, or late decelerations caused by uteral and placental insufficiency, and you also have variable decelerations. In this slide, you see accelerations. In accelerations, the peak is at least 15 beats per minute above the baseline, and the acceleration lasts 15 seconds or more. This one is more than 15, it's more like 25 above the baseline, and it lasts for 10, 20, approximately 30 seconds. with a return to baseline less than 2 minutes from the beginning of the acceleration. Acceleration in the fetus before 32 weeks gestation is defined at a little bit less, at a peak of 10 beats per minute above baseline and a duration of at least 10 seconds. An acceleration of the fetal heart rate greater than 10 minutes above the baseline is no longer considered an acceleration, but a change in a baseline heart rate. Accelerations can be either periodic or episodic. They may occur in association with fetal movement or spontaneously. Accelerations can be stimulated through vibroacoustic stimulation or fetal scalp stimulation. Accelerations are considered a sign of fetal well-being and an intact neurological system. Early decelerations in the fetal heart rate indicate head compression. They are visually apparent. Onset to the lowest point is generally greater than or equal to 30 seconds. They usually begin by the onset of the contraction and return to baseline by the end of the contraction. This is considered a normal finding. Because of the relationship to the contraction, early decels are often called the mirror image of the contraction. Early contractions usually occur early in labor when the cervix is dilated 4 to 7 centimeters. However, they may be seen during the second stage when the woman is pushing. These are considered benign and therefore intervention is not wanted. If you look at these contractions, they go down and back up with the contraction. They look very similar to the contractions and look like a mirror image. Early decelerations. This also shows early decelerations. The same thing. You see the deceleration go down with the contraction. Looks very similar. Looks like a mirror image of the contractions below. Late decelerations begin after the contraction has begun and do not return to baseline until after the contraction is over. The onset to the lowest points is greater than or equal to 30 seconds. Generally, late decelerations are associated with uteroplacental insufficiency, but they can be seen with maternal hypotension, uterine tachysystole, preeclampsia, postdate or postterm pregnancy, amnionitis, small for gestational age fetuses, maternal diabetes, placental previa, placental abruption, conduction anesthetics, maternal cardiac disease, and maternal anemia. They should be considered an ominous sign, especially when associated with absent or minimal variability. Uterine tachysystole as a result of Pitocin administration can also cause late decelerations. If you see in this here, you see that the contraction is peaking here. The deceleration does not start until after the peak of the contraction. It does not return to normal until after the contraction is over. You see this with each and every one of these decelerations on this slide. Late decelerations. This also shows late decelerations with accompanying minimal variability. If you see, not only do you have accompanying minimal variability, but you also have a fetal heart rate baseline of around 170s. So you've got a fetal heart rate baseline running 160 to 170, which is a little tachycardic, not tremendously tachycardic, but it's a little tachycardic. And then you have late decelerations and minimal variability. Nursing interventions with late decelerations include changing the position of the mother, correct maternal hypotension by elevating the legs, increase the IV rate, palpate the uterus to assess for tachysystole, discontinue oxytocin, administer oxygen at 8 to 10 liters per minute via non-rebreather, notify the physician or nurse midwife, consider internal monitoring for more accurate fetal and uterine assessment, and assisting with birth, either vaginal or cesarean, if the pattern cannot be corrected. Variable decelerations of the fetal heart rate are defined as a visually abrupt and apparent decrease in fetal heart rate. The onset to the lowest points is generally less than 30 seconds. The decrease is at least 15 beats per minute below baseline and lasts at least 15 seconds and returns to baseline less than 2 minutes from onset. Variable decelerations can occur at any time during the uterine contraction phase and are caused by umbilical cord compression. Variable decelerations may be either U, V, or W-shaped and are characterized by a rapid descent and to and ascent from the nadir of the contraction. Prolonged decelerations is a are a visually apparent decrease in the fetal heart rate of at least 15 beats per minute below the baseline and lasting more than 2 minutes but less than 10 minutes. A deceleration that lasts more than 10 minutes is considered a change in baseline and not a prolonged deceleration. They are caused by a prolonged interruption in fetal oxygen supply. This slide shows variable decelerations. Note that no two of these decelerations look alike. Some have shoulders, which is an acceleration immediately prior to the deceleration, or an acceleration immediately after the deceleration. However, occasionally variable decels have little clinical significance. However, recurrent variable decelerations indicate a repetitive interruption in oxygen of the fetus. This indicates a repeated cord compression and can be seen in situations where the cord may be wrapped around the neck, arm, or other fetal body part. Variable decelerations are most often seen in the transition phase of the first stage of labor or the second stage of labor as a result of umbilical cord compression and stretching of the cord during fetal descent. In this slide, you see two variable decelerations. With each, you see a pattern on the uterine contractions that's not smooth, it's very jagged. This indicates most likely that this mother is pushing. However, if you see variable decelerations that are repetitive, nursing interventions may be necessary, and these include changing the maternal position, side to side, knee chest, discontinuing Pitocin if infusing, administering oxygen at 8 to 10 liters by non-rebreather mask, notifying the physician or nurse midwife, assisting with vaginal or speculum examination to assess for cord prolapse, assist with amnio infusion as ordered, and assist with birth, either vaginal or cesarean if pattern cannot be corrected. In this slide, you see prolonged decelerations. Examples of conditions that can cause prolonged decelerations include maternal hypotension, uterine tachysystole or rupture, extreme placental insufficiency, and prolonged cord compression or prolapse. The degree of hypoxia is correlated with the depth and duration of the deceleration, how abruptly it returns to baseline, and how much variability is lost, and whether rebound tachycardia and loss of variability occur after the deceleration. In these prolonged decelerations, once again, you see that it looks like probably mom is pushing. You may see some prolonged decelerations during pushing. In this case, depending on how close we are to delivery, I might give the mother some oxygen. I might coach her on breathing. It depends on exactly what's going on in this situation. You can definitely see that these are prolonged deceleration. The heart rate goes down here, and it's down for 1 minute, 2 minutes, 3 minutes, and finally begins to return to baseline right here at about 4 minutes. So this is definitely a prolonged deceleration. Care management with fetal monitoring. Once it has been assured that the monitor is recording properly, regular assessment of fetal heart rate and uterine contraction tracing should be evaluated throughout the labor. Guidelines for perinatal care published by the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists recommend that the fetal heart rate tracing be evaluated at least every 30 minutes during the first stage of labor and every 15 minutes during the second stage of labor in low-risk women. If risk factors are present, and the tracing should be evaluated every 15 minutes in the first stage of labor and every 5 minutes in the second stage of labor. Today, evaluation of the strip has been made much easier with the advent of central monitor displays that allow the nurse to monitor several patients at one time. Physicians can access the tracing from a remote location in order to assess the strip without being present. A checklist for assessment of the fetal monitoring equipment can be found in your book. When evaluating fetal heart monitor pattern, it is important that the nurse be able to quickly evaluate if the pattern is normal or abnormal. Then evaluate other factors to consider the anticipated time of birth and to determine if the intervention is needed. Categorizing fetal heart rate tracings. They are categorized as either Category 1, normal, that does not require specific action, Category 2, which is indeterminate, that require continued observation and evaluation. Category 3, which are abnormal, immediate evaluation and prompt intervention are required when these patterns are identified. Nurses are legally responsible according to the standards of care to correctly interpret fetal heart rate patterns. There are additional methods of assessment and intervention. If the fetus seems to be asleep, there are methods to check for fetal response. In general, a fetus with an intact central nervous system will respond with accelerations in the fetal heart rate when stimulated. The two methods of stimulation are fetal scalp stimulation done upon vaginal exam and vibroacoustic stimulation. Umbilical cord blood may be drawn immediately after birth to assess the pH, CO2, and O2 levels in both arterial and venous cord blood. Samples of fetal scalp blood for pH may also be drawn. The procedure is performed by obtaining a sample of fetal scalp blood through the dilated cervix once the membranes have ruptured. Amnioinfusion may be performed. This is done when an isotonic room temperature fluid, usually lactated ringers or normal saline, is infused through the uterine pressure catheter into the uterine cavity if the volume of amniotic fluid is low. This can help in alleviating cord compression. Tocolytic therapy may also be necessary. If other methods of managing fetal stress are not successful, tocolytics may be administered to relax the uterus. Tocolytics may be administered when a woman is having excessive uterine contractions or when a cesarean birth has been decided upon while giving time to prep for surgery. The most common tocolytic used is terbutaline or breathine. The nurse should be sure to teach the patient about the reason for fetal monitoring. If any changes are made as a result of the fetal monitor strip, it is important to inform the mother of the reason for the change and to appropriately respond to the emotional, informational, and comfort needs of the patient. In most labor and delivery suites today, documentation is computerized and can be done at the bedside. However, some facilities require that the nurse physically note on the strip when she is present in room with the patient. This concludes your lesson 3 of your intrapartum unit. This lesson is from your textbook, Maternal Child Nursing Care, the chapter on fetal assessment and labor by Cashin.